I am Dr. John Hodgkin, Medical Director of the Smoke-Free Life Program in St. Helena, California. I am happy to speak on behalf of our collaborative research team from the St. Helena Center for Health, the Palo Alto Center for Pulmonary Disease Prevention, and the Center for Health Sciences at SRI International in Menlo Park, California. Our team developed the article, Outcomes from a Patient-Centered Residential Treatment Plan for Tobacco Dependence, which is to appear in the September 2013 issue of Mayo Clinic Proceedings. Tobacco dependence is significant. It causes 18.1% of all deaths in the United States and accounts for a greater proportion of U.S. healthcare costs than any other single factor. Untreated, about 97% of those trying to quit smoking relapse within 1 year. St. Helena Hospital in St. Helena, California, launched the first U.S. residential stop smoking program in 1969, with the Mayo Clinic in Rochester, Minnesota, opening a similarly structured program in 1992. In order to assess the effectiveness of St. Helena Hospital's residential smoke-free life program, data from all 305 smokers who participated in 2005 through 2007 were evaluated. At 12 months, 57% reported that they had not smoked in the previous 7 days, and 40% reported that they had not smoked since leaving the program. Non-medication components of the program included individual and group behavioral counseling, interactive educational sessions, implementation of regular exercise and good nutrition, and consideration of the role of spirituality. A physician discussed medication options with the patient, and together they developed an individualized medication plan which could have included any combination of long and short-acting medications. Long-acting medications included the nicotine patch, bupropion, and varenicline. Short-acting medications include nicotine nasal spray, nicotine oral inhaler, nicotine gum, and nicotine lozenge. Most participants started taking medication on day 1 when they stopped smoking. From days 2 through 8, a physician or nurse practitioner assessed each patient daily to consider the need to adjust medications. Of the 236 patients using the nicotine patch, 49.5% of our patients used the combination of nicotine patch, bupropion, and short-acting nicotine medications and achieved a 7-day point prevalence smoking abstinence outcome at 12 months of 63.9%. 97.4% used at least one additional medication, and 75.8% used more than the standard beginning nicotine patch dose of one 21 milligram patch per day. Patients were advised to maintain all medications, combinations, and dosages for at least an additional 3 to 4 months after discharge before starting to taper off the medications. We followed up each patient by telephone at 1, 3, 6, 9, and 12 months after discharge. Any participants that we could not reach were classified as smoking. None of the baseline variables, including age, gender, pack years smoked, comorbid conditions, and the Fagerstrom test for nicotine dependence, or FTND score, were associated with smoking outcomes. Although other studies have found that higher FTND scores are associated with a lower likelihood of quitting, this was not the case in our study. The figure in our article showed that for those using nicotine patches, with increasing FTND severity, the proportion of patients smoking at 12 months was not significantly different, whereas the number of patches used had a significant upward trend. We believe that for those using nicotine medication, the use of enough nicotine to achieve levels equivalent to those experienced while smoking can improve stop smoking outcomes by minimizing nicotine withdrawal symptoms. The 57% smoking abstinence rate at 12 months for participants in our residential program is very favorable. The Mayo Clinic Nicotine Dependence Center reported a 7-day point prevalence smoking abstinence rate at 6 months of 52% for their residential program participants and 27% for outpatients for the period of 2004 through 2007. Although residential programs offer a unique setting to provide tobacco dependence treatment, many patient-centered features, such as the simple act of listening and tailoring medications, can be translated successfully to outpatient practice. A residential stop smoking program should be considered for those who have been unsuccessful in achieving tobacco abstinence despite serious attempts in the outpatient setting.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.com. This video content is copyrighted by Mayo Foundation for Medical Education and Research.